Hello and welcome to Module 3, Lecture 2, Introduction to Community Health. On week 5, we'll be defining an HMO, Health Maintenance Organization, and Managed Care Organizations, understanding the difference between PPO and EPO, and analyzing some advantages and disadvantages of managed care. Your homework were Chapter 9 of your textbook, Managed Care Impact on Healthcare Delivery, just glancing through this CMS website on what managed care is. There's a Washington State Healthcare Authority video about how behavioral health or mental health is getting merged into managed care for physical health. So that's a good example here. And Benefit Compare is just a company, but it gives a good description of what the different plans are and how they work, and sort of it's geared towards the consumer. So it's kind of interesting to watch. I'd like to give the credit for this PowerPoint that you're about to see for the presentation to Nancy Niles, the author of your textbook, and jblearning.com. First, a few random facts. Managed care has been a concept since the 1930s. The oldest form of managed care is the Health Maintenance Organization, HMO. Carve-outs are healthcare services that will not be paid by managed care organizations, which could include experimental treatment, drug costs, behavioral health costs, and in the Washington Health Authority video, you'll see how that changes in our state. And I believe a lot of advocacy was done to change that, and so that's a example also of a win for behavioral health, mental health advocates. So just to begin with, managed care refers to the cost management of healthcare services utilization by controlling who the consumer sees and how much the services cost. Managed care organizations were introduced 40 years ago, but became more entrenched in the healthcare system when the HMO Act of 1973 was signed into law by President Nixon. So managed care plans basically, in a nutshell, establish relationships with organizations and providers to provide a designated set of services to their members. They establish criteria for their members to utilize the MCO. They establish measures to estimate cost control. They provide incentives to encourage health service resources. So sometimes they'll provide free preventive services or other incentives like that. They provide and encourage utilization of programs to improve the health status of their enrollees. So managed care models, health maintenance organizations, or HMOs, are the oldest type of managed care. Members must see their primary care provider first in order to see a specialist. And in one of the videos, they even called it a gatekeeper, which sometimes they call it that in an HMO where it's required to see your primary care physician, so they're like a gatekeeper to other services that you can get, a referral to, ear, nose, and throat doctor, or a referral to an endocrinologist or some other type of healthcare. Even, I think, to social services, I could be wrong, but PCPs or primary care physicians are often called gatekeepers. There's a staff model, which hires providers to work at a physical location. That's one type. There's also a group model, which negotiates with a group of physicians exclusively to perform services. This was the first type of HMO model introduced by Kaiser Permanente. Managed care models, the network model is similar to the group model, but these providers may see other patients who are not members of the HMO, but that are in the same network. So the independent practice associations, IPA, contracts with a group of physicians who are in private practice to see MCO members at a prepaid rate per visit. The physicians may sign contracts with many HMOs. Managed care models The preferred provider organizations. So if you have healthcare from your employer, you might see PPO as an option for your benefit package. They do not have a gatekeeper like the HMO, so a member does not need a referral to see a specialist. They do not have a copay, but they do have a deductible. And developed by providers and hospitals to ensure that non-members could still be served while providing a discount to managed care organizations for their members. So other models, exclusive provider organizations, which are actually EPOs, but they call it EOP. They are similar to PPOs, but they restrict members to the list of preferred or exclusive providers members can use. And so, again, they don't require a gatekeeper or a primary care doctor to send out the referrals. Physician hospital organizations, PHO, these organizations include physician hospitals, surgical centers, and other medical providers that contract with a managed care plan to provide health services. Oh, sorry about that. So MCO provider remuneration with a capitation policy or per member per month policy, the provider is paid a fixed monthly amount per employee, which is often called a PMPM payment. So we're basically just here talking about different ways that primary care or just doctors are paid for their services in a managed care organization. And so capitation is one way, discounted fees are a type of fee for service. So capitation is one policy, fee for service is another policy. But it's discounted with an MCO so that it's based on a fee schedule. The provider provides the service and then can bill the managed care organization based on the fee schedule. Salaries are the third method of payment for providers, and in this instance, the provider is actually an employer of the MCO. Cost control measures of MCOs. So one of them is restricting provider choices for the patients, and members of an MCO often have restrictions on their choices. They can only go in network. Gatekeepers are another cost-cutting measure in which some MCOs enforce that patients must see a primary care provider as the gatekeeper of all the care for that patient member. Any secondary or tertiary care would be coordinated by the gatekeeper, and what they mean is the referrals would be all coordinated by this one primary care doctor. So the cost control measures of MCOs, utilization review. Oh, and just going back for a second, I think this gatekeeper can also be a nurse practitioner and a physician assistant. Might have to check on that, but I think any primary care provider doesn't have to be a doctor. Anyway, so cost control measures of MCOs, utilization review. So this is important in MCOs. They evaluate the appropriateness of the types of services provided. There are 3 types of utilization reviews: prospective, concurrent, and retrospective. Again, for community health, just putting all these cost control measures in perspective, including the prospective review, which is implemented before the service is actually performed by having the procedure authorized by the MCO based on clinical guidelines. And the relevance for us is just whether MCOs are prioritizing cost cutting or whether they're patient-centered and caring about the community or the patient involved. And so that's what we want to look at, and that's why knowing this information is important for us. How the healthcare system works will in turn help us be better healthcare providers and advocate better for patients when we know how costs are cut or how money is spent in the healthcare system. So just to put it all in perspective here, other cost-cutting measures, cost control measures in MCOs are concurrent utilization reviews, which are decisions that are made during the actual course of service, such as length of inpatient stay or additional surgery. Retrospective utilization review is an evaluation of services once the services has been provided. This may occur to assess the treatment patterns of certain diseases, and all of these types of reviews are important. Not to say that cost control isn't good. Often evaluating whether patients need more surgeries is helpful very much to the patient as well, to spare them from unnecessary procedures. So Medicare Managed Care, Medicare Part C, implemented in 2000, the purpose of Medicare Plus Choice was to encourage Medicare enrollees to use managed care services. Medicare offered risk plans and cost plans for their enrollees. Risk plans pay a premium per member, which is based on a county of resident basis. Members could use both in-network and out-of-network providers. The risk plans covered all Medicare services and vision and prescription care. So this is Medicare Part C. Medicare cost plans reimburse the managed care organizations on a preset monthly basis per enrollee based on a forecasted budget. The cost plans allowed members to pursue care outside the network. So again, this is another way of accessing managed care organizations through Medicare. In 2003, the Medicare Prescription and Drug Improvement and Modernization Act, which was, you saw that in SICO, President George Bush Jr. mentioned it for a minute. So it was renamed the program Medicare Advantage later and allowed the option of PPOs as an option. It also allowed enrollees to participate in private fee-for-service PFFS plans as part of the Medicare Advantage. Medicaid managed care, so that was Medicare, this is Medicaid. All states except Alaska and Wyoming have Medicaid managed care. Managed care plans use the gatekeeper model, HMOs, and prepaid health plans. Carve-outs are services that Medicaid is not obligated to pay for under an MCO contract. And carve-outs have occurred because the MCO cannot provide the service or it's too expensive. Unfortunately, mental health services and substance abuse treatment services are often categorized as carve-out services, but you'll see in Washington State how it works through the video that's on your media list and how behavioral health, mental health is being combined with physical health care into a single managed care organization. So you'll see this is true for many MCOs and for different states, and you'll see how it works in Washington through the video. MCO assessments, the National Committee on Quality Assurance was established in 1990 to monitor health plans and improve healthcare quality. The NCQA accredits MCO, although a voluntary review process. It includes surveys by managed care experts and physicians. The Health Plan Employer Data and Information Set, HEDIS, were established by the NCQA in 1989. It is used by nearly 100% of all health plans to measure service and quality of care. The reported data is available to MCOs and physicians. I would like you to look up HEDIS measures between now and part 2 of this lecture. Just browse through the website and I will see you next time. There'll be a link on your slides that you can click to get the measures. See you next time.